Good afternoon to everybody. So, personalized PEEP in ARDS is the title of the session, using thoracic CT scan. Good. Let's see first just a few words about the recruitment. The recruitment is a term which indicates enrollment of something to one status to the other status. Was used for the military, for the soldiers, but in general may consider as the enrollment of pulmonary units in a new status. And this new state regards the aeration and, always forget, the perfusion. And so the state according to which the recruitment could be defined may be a state in which we have pulmonary units without gas, that means atelectatic units which are empty and usually compressed, and they go in a new state where some gas is available. Or somebody else defined more in general recruitment for the same pressure. Maybe you put the pulmonary unit in more favorable mechanical condition for which some regions get more gas. What is always forgot is the perfusion, because the PEEP, just for a moment the protective strategy and so on, speaking about the gas exchange is a function of gas and is a function of perfusion. So if we recruit, as an example, without perfusion, we cannot expect any change in gas exchange. We have just a mechanical exercise. So the assessment usually is done by gas exchange, and this is perfusion dependent. And we have two other systems, lung mechanics, perfusion independent. These are the gas-based method. We will examine them, but we spoke before that in the previous lectures. And then we have the CT scan. The results of the CT scan are perfusion independent. Let's see, perfusion dependent gas exchange. This is an old paper from Danske, has been reconfirmed. And Danske will say, okay, when I use to assess the recruitment, looking at the increase of PF, and I'm very happy. So increase PF, we're going to increase PEEP, that means recruitment. Not at all. That means not necessarily true. As an example, you have a lot of patients in which increasing the PEEP led to increase of PO2 and decrease of shunt, but we just was parallel to the changes in hemodynamics. As an example, these are patients in which we looked at the change in normally inflated tissue, so how much the tissue regain aeration. And you can see, in some patients, we increase the normally inflated tissue up to 20-30% without any change in shunt. That means these are recruitment of perfused regions. Then we have some patients in which we decrease the shunt, but the recruitment of the pulmonary units does not happen. And these are blood flow diversion, that we have patients in which the change in tissue correspond to change in shunt. So that means when you look only at the perfusion, be careful with the PO2. Then we have lung mechanics, and we have an example, a series of methods based on the expected ELV. When I change PEEP, as an example, increase the pressure, I expect for a given compliance and a certain amount of change in that volume, I get a more volume. That means I have more gas, and this is called recruitment. The same principle applied to the dual VP curve and applied to RI ratio, and we had a lecture about that before. It's important to understand that this recruitment does not include any information about the gas exchange, about the perfusion, and this recruitment includes opening the new units plus a more favorable mechanics of other units which are already open. As an example, here we have a volume pressure curve in a normal man. You see that if I have the pressure at this level, or at, for the same pressure, for the same change in pressure, I may have a change in volume. Means in these regions, the mechanics of the respiratory units are more favorable. That means they get, for the same delta pressure, they get more delta volume, which is read with the gas method as recruitment. And this, as an example, a study that we did with Humel a few years ago, you have the PV curve system and the compliance-based system, and you see there is a perfect agreement with a very reasonable standard deviation around. But what about the CT scan? With the CT scan, this is a normal distribution of pixel in a normal man. In a CT scan, we have a part of the pixel which are completely airless. And we say, okay, we define a recruitment as the amount of pixel in this region which regain aeration. And this is the recruitability. Using this system, we found in RDS that the recruitability, that means the potential of recruitment going up with the pressure up to 45, in some patients is nil, or very poor. In some patients is extremely high. As average, we may recruit about the median values is around 9–10% of the lung parenchyma. And you know, in the lower regions, the recruitment is very visible, 59 grams. Why 3,700 grams in the higher recruitability regions? But look at the huge variability we have. Why we have this variability? Because for the same pressure, for the same high pressure, depending on the severity of the lung injury, that means depending on the anatomy of the lung, we may have a lot of recruitment, here in severe, as an example, in patient undergoing ECMO, here in severe patient without ECMO, here in moderate RDS, here in mild RDS. You see the recruitment goes from 100 grams up to 400 grams. Here we have 600 grams, in a mild RDS we have less than 100 grams. So there is no gas method that can give you results like this. And this is quite clear, this is an apparently complicated slides, but these are the compartments of alpha unit tissue. That means here we have the tissue at PEEP of 5 and PEEP of 15, the tissue with a very, very small amount of gas. And this is what we call recruitment. It's very marginal. But you see that the gas goes, these are the gas compartment, the gas, when increase the pressure, goes primarily in units which are already very well open. Look here, this is the normal compartment, 800, 700, 900, 800. Most of the gas goes there. That means when you put pressure, the lung accepts the pressure when there is more compliance. And this is another view of the same problem. And if we compare the recruitment as assessed by the CT scan, this is the CT scan, or by the VP curves, or compliance method, you can see that we do not have almost any relationship. So when the people measure at the bedside, you get one number. You may get an overall indication, but you have nothing. This has nothing to do what we measure with what you measure using the CT scan. How is the CT scan is important? Just let me give you a very short example. This is an early COVID, so this update. Supine 5 centimeter water. These are supine 35 centimeter water. That means at the 35 centimeter water inflation, and you see the gas recruitment is 8%. With the gas method, you have far more, but you don't have great changes here. This is in prone position. And look here, in another patient, look at these densities, they completely disappear. And the density move in prone position, 5 and 35. And there is no other method that can give you the general picture of the lung status and to its response to pressure as the CT. I know that is not easy, but give you a perfect panorama of the patient you are treating, give you the most information you need. Look here, this is a patient late COVID. Look at this density. Are very different from this density? They do not appear very different. Look at the recruitability here. Recruitment is 0%. You adjust over this tension here. And look when you put the patient in prone position. All the densities stay up where they were. So don't ask me how much is the recruitability in COVID pneumonia. This question doesn't make any sense. It depends at which moment you observe the patient. So in general, just a few words about PEEP. When you use a low PEEP or higher PEEP, we just compare the risk of atelic trauma versus the risk of the volotrauma. If you have low PEEP, we do not have volotrauma, but we have some opening and closing. If you have high PEEP, we do not have volotrauma, we don't have atelic trauma, but we have a lot of volotrauma, of possible expansion. And we have differences in the possibility in hemodynamic, in gas exchange, and so on. But what about the mortality, which is the goal on which all the physicians look? Well, we know that lower PEEP and higher PEEP, if we explore the range of PEEP between 7 and 15, the risk of barotrauma, and the risk of volotrauma, and the risk of atelic trauma are exactly the same. The mortality is impressively the same. Now you can do whatever subgroup analysis and so on you want. These are the raw data. That means within this range of pressure, lower or higher PEEP are equivalent. But if you use higher PEEP than 15, the volotrauma wins. So I think in the last minute that a CT scan is one of the possible methods, but what measures the CT scan is not what is measured at the bedside. Is not what is measured with the lung mechanics. These amounts are not related. In my opinion, at least once when you receive the patient with a severe ARDS, or you want to understand how the patient is made, what is the response to the pressures, measuring in the same time the gas exchange, I think the gold standard is CT scan. More you measure, more you know. More you know, better you treat. Thank you for the attention.